Good evening. This is JoyNews National Dialogue on Ghana's emergency care crisis. Tonight, we focus on a crisis that continues to raise troubling questions about Ghana's emergency healthcare system. Why are critically ill patients still struggling to get timely emergency care? Why are families being forced to move from facility to facility in search of help? And what must change urgently to save lives? This discussion goes beyond the headlines. It is about policy preparedness, access, accountability, and the human cost of delay. Tonight, we'll hear from medical experts, policymakers, and affected families. We will also share data, field experiences from northern Ghana and other parts of the country. And you, our cherished viewer, can also be a part of the discussion by sending us your messages and sharing your experiences on the number 0302-211-691, or you can leave a comment on any of our social media platforms, be it Facebook, X, Instagram, and YouTube. I'll gladly share it with the rest of the world. My name is Kenneth Jesse. Welcome. Let's begin with a report that sets the stage for tonight's discussion and highlights the scale of concern around access to emergency care.
ENA was so much congested that there was no bed. They were depriving us from getting inside, but it was so serious issues. People were sitting in plastic chairs, sitting down, lying down to get health medications. For me, I don't get it right because I know the doctors, for me, I'm very happy. They work very intensively to save people. The doctors,
tell us about the conditions inside the accident and emergency.
The condition is that no bed. People were sitting in plastic chairs. People were sitting down, lying down to get health, to get medications.
Tell us about the conditions inside the accident and emergency.
The condition is that no bed. People were sitting in plastic chairs. People were sitting down, lying down to get health, to get medications. Yes.
My younger brother was involved in an accident, and then we got to Konfanoche. The ambulance conveyed us to Konfanoche around 3:30 p.m. thereabouts. So it was around 3 a.m., 2:30, 3 a.m. That was when we got to bed. And even that one, we had to see some people, and then we had to unsolicited grease some palms, and then just to facilitate the process for us. And then I saw a lot of people there who were in severe pain, going through severe pain, but then they also couldn't get a bed. And it's a very, very devastating experience, honestly.
You're watching JoyNews National Dialogue on Ghana's emergency care crisis. The concerns are not only emotional, they are systemic. There are persistent questions around bed capacity, referral systems, emergency response, staffing, equipment, financing, and coordination between health facilities. Tonight, we'll also be sharing key data and trends that help explain why the problem persists and why many Ghanaians believe the system is failing some of its most vulnerable patients at the most critical moment. Let's go to our touch screen right now and run you through the data that we have. So this is the combined bed capacity of Ghana's 5 teaching hospitals. So if you combine the bed capacity of all the 5 teaching hospitals that we have in the country, it is 4,652. The combined capacity of beds in Ghana's 5 teaching hospitals, as I mentioned earlier, this is what we have. And then Kolebu Teaching Hospital and Konfanoche Teaching Hospital have more than 50% of this particular capacity. They have over 68% of the bed capacity of all the 4 teaching hospitals that we have in the country. Let's focus on Kolebu Teaching Hospital right now, shall we? And the bed capacity of Kolebu Teaching Hospital is 2,000. That's the figure there that we have on the screen for you. The daily patient volume is 1,500. So that is every day you see about 1,500 patients trooping to Kolebu Teaching Hospital alone. And that is one of the 5 teaching hospitals that we have in the country. the daily patient admissions. So if these patients go, most of the time, about 250 of them are admitted at the Kolebu Teaching Hospital. Let's take you to the Ashanti region and talk about the Komfo-Anokye Teaching Hospital, which has a bed capacity of 1,200. And the daily patient volume, the daily patients that troop into the Komfo-Anokye Teaching Hospital is a little above 1,000. The figure hovers around 1,093. And the daily patient admissions is 150. So every day we have 150 patients being admitted at the Komfo-Anokye Teaching Hospital in the Ashanti region. Right, and the number of healthcare personnel under Ghana Health Service. This is the latest figure we have from 2025, and this is it. We have a total of 1,625 doctors, according to the statistics that was provided to us by the Ghana Health Service. And if you're to do the ratio, we have a population of approximately 31 million people. So if we do the tabulation, you see that one doctor is equal to 19,000 residents. That's the population ratio of doctor to the population here in the country. The surgeons, the number is not actually encouraging. We have 95. And if you do the ratio, you have one surgeon is to 326,000 people. And we have specialists. We have some medical officers who specialize at a particular field. That one, you have 642 of them, and one specialist is equal to 48,000. One specialist is equal to 48,000 when you do the personnel to population ratio. And then you have nurses and community health nurses. Nurses and community health nurses, if you see the CHN, that's what it means. We have more than 71,000 of those. If you combine the nurses and the community health nurses, we have more than 71,000 of those. And so combined forces of nurses and community health nurses equal one community health nurse and one nurse equal to 433 of the population. And then we have some health officials who are also unemployed. They're currently at home. They have not been enrolled into any of the health facilities across the country. These are the figures that we have for you. That is over 70,000. Over 70,000 health personnel across the country who are qualified to be enrolled onto the various health facilities across the country. They're currently unemployed and they are at home. And the interesting thing is that we have about 13 countries seeking to recruit them. So you often hear of nurses moving outside of the country to the UK, to other European countries to seek greener pastures. These are the figures. If you look at the doctors, out of these figures, you have over 900 qualified doctors who are currently unemployed. They are not employed at any health facility in the country. Then we come to the nurses and the community health nurses as well. We have over 48,000 of them. The exact figure is 48,878 of these qualified nurses and community health nurses who are currently unemployed. We have allied health professionals. They are over 21,000. The approximate figure is over 21,000, and if I'm to give you the exact figure, it's 21,570. So in all, if you combine all these numbers, you have over 70,000 health workers who are currently unemployed and are sitting at home. Then we look at the composition of Ghana's health budget. This is the health budget that we have, the latest figure from the Finance Ministry. The health budget is 22.8 billion. That's the budget for the health. If you see this graph, you see that the red one is salaries, the blue one is others. And if you look at the figure or the map carefully, you see that only salaries paid to health workers take a chunk of their budget. You have over 65% of the budget going into salary payments. The blue that you see here is 34.1%, which is others. So the others caters for everything that you see them work with, infrastructure, everything to ensure that these health facilities are up and running. So this is the staggering figure that we have for you. If you look at the total budget, the latest figure that we're getting from the Finance Ministry shows that it is 22.8 billion Ghana cedis. That's the budget for the health sector. And out of that, over 65% of that goes into salary payments. And you have 34.1% of this going into others, which caters for virtually everything apart from salary in the health sector. And this is not just about isolated incidences. It is about whether the system is able to respond when lives are hanging in the balance. Let's welcome my guest tonight for the discussion. We have Dr. Grace Ayensu, who is the Deputy Minister for Health. Dr. Winfred Ba is the Registrar of Health Facilities Regulatory Agency, otherwise known as HEFRA. Dr. Joseph Boni is an emergency medicine specialist. Perpetua Ofori Ampofo is the president of the Ghana Registered Nurses and Midwives Association. Dr. Kwame Esiedu-Sapon is a CDD fellow, and also will be joining us a bit later on Zoom will be the Deputy Director of Konfanochi Teaching Hospital, Dr. Yao Oparilabi. Dr. Darius Osei is a former CEO of the University of Ghana Medical Center, also known as UGMC. Dr. Levi Ankra is the Vice President of the Kolebu Doctors Association. Thank you very much, ladies and gentlemen, for making time to join me this evening. And this is the Joy News National Dialogue on Ghana's emergency care crisis. When we return from the break, we will touch base with our correspondents, speak to the relative of a hit-and-run victim, and then set the ball rolling for what promises to be an impactful 3 hours. Don't go anywhere. Welcome back. You're watching Joy News National Dialogue on Ghana's emergency care crisis. Let's now crisscross the country and speak to our correspondents. Let's begin from the Ashanti region, where Clinton Yeboah is joining us with the latest. Clinton, how is the emergency care situation in the region? Right, and before we get into the policy and technical discussions and before we get to Clinton, it is important to remember that behind this issue are real people and grieving families. We'll now speak to the sister of a motor rider who was involved in a hit-and-run incident and later died after reportedly struggling to get emergency care. Matilda Amisa, who herself is an emergency doctor at the Cape Coast Teaching Hospital. Thank you very much for joining us. We're so sorry for your loss, Matilda. Tell us where you were when you heard about this tragic incident that resulted in the sad loss of life of your brother.
Thank you for giving me the opportunity. I was at the emergency Cape Coast Teaching Hospital when I received a call that, my brother was missing and I didn't know what to do. So we started searching for him. We had to escalate to all media platforms, social media handles, even on the doctors' platforms, nurses' platforms, so that they could search for him. We searched through a couple of hospitals around the Promasidor area because that's where he worked. He worked at Promasidor. He was an engineer there. So we searched hospitals around that side, went through Achimota Hospital, went to Kolebu Ridge, but those on duty do not recall any accident coming to their facility. And someone was also picking his phone calls, but not answering not responding to our questions. So we thought it could be a kidnapping. So we kept searching. That the incident happened on a Friday. We searched, reported to the police after 24 hours since he left the house. And they also wanted to started their investigation, but it was very slow because it was a weekend. And then they told us that by Monday, they should be able to give us feedback. So that's our Denta police station. So we went back there, but still there was no response. We hadn't heard anything. and we were still searching for him as like a missing person. We never thought it would come out that he died. So it was Tuesday that Nima police station called us that there was an accident, and that, I mean, this is what happened to Charles. We should come and identify the motorbike. We went there, and truly it was his motorbike. So that was where the commander narrated the story that he was sent. He actually had the accident on the Circle overpass towards Nima, and he was carried by national ambulance because they were right there under the bridge at Circle. They were able to pick him up, and then they transported him to police hospital where they said that they didn't have a bed space for him. When they tried to negotiate to use the trolley, but they insisted they should go to Rage Hospital. And they went to Rage, the same thing happened, negotiated, but it didn't, they told them to go to Polibu. So this is where, I mean, Commander is narrating what National Ambulance had told them, because it was truly National Ambulance that called them to say that the missing person that is circulating, we think that it is this 46-year-old person that we reported to you, I mean, some time back. So that is from National Ambulance to the commander of the Nima police station. So they called us, and so we went there. She narrated this according to, I mean, what the story that had happened. Apparently, they also sent a CID to the scene, and he retrieved the motorbike. And his story was also similar. I mean, he followed up with the National Ambulance, but nothing. He also didn't get any response. He returned to Nima with the motorbike. So they told us that, okay, if we've been able to identify the motorbike, let's go and see if the person we are talking about is truly your brother. So we went to the Kolebu morgue. And over there, it was heartbreaking. We got there and we're told that, oh, he's lying amongst some bodies, and I cannot cross over bodies to go and identify him. So they'll put him on a trolley and then bring him out. So they did so. I mean, he wasn't even put in a cold room or anything. So he had started to decompose. And they asked me if it was truly my brother, and I said, yes, it is him. So it was after we identified, we were able to go back to Nima police station to confirm that it was truly, I mean, Charles Emisa. It was heartbreaking looking at his wounds, a deep wound to his right shoulder, and some burns. I mean, probably he was dragged on the floor, so some burns, frictional burns, that's what we call it, around his arm. That's what we noticed. We went back to the commander to tell her that it's truly Charles Emis. So it was the following day, that was the Wednesday, that we saw news circulating that there was an incident report from National Ambulance describing the events that unfolded, that he was sent to police hospital. So it coincided with what the commander had said. So it's like, yeah, this is, even though the situation analysis said a 46-year-old, I also went to the morgue, and then it was a 46-year-old unknown that was on the paper. And his stature looks it, because he's bald-headed, he's tall. He was tall, very hairy. He was a very, I mean, heavy person. So, I mean, I understand why they might put a 46-year-old person there, but we changed it from the 46 to the 29-year-old at the morgue and changed the unknown to his full name. That's Charles Henry Emisa. And then they followed the morgue process. Now there's a relative, so they followed the morgue protocol to put him in the fridge. So it was at the Nima police station that, I mean, they narrated the story. So when we saw the situational analysis, I was like, yeah, this is my brother. This is my brother's report circulating. I know how the media go hold of, this is my brother. And then connected the dots, and it was already, in the public that the person that the ambulance drivers picked up was truly Charles Henry Emisa, the engineer.
So sorry once again for your loss. You are a medical practitioner yourself
Officer.
a medical officer yourself at the Cape Coast Teaching Hospital. When you realized that your brother had sadly lost his life and you noticed what had killed him and you evaluated it within you, what do you think, or how close do you think your brother would have been to being saved if emergency care responses were on time?
Yes. So the timing, looking at the timing from the time that the ambulance people picked him up was roughly 3 to 4 minutes, and I believe it because they are really down the bridge, so it wouldn't take them long to pick him up. But he got to police hospital in another 4 minutes, 4 to 5 minutes, and I felt like police hospital should have at least looked at his injuries and try to, if not secure, we call it secure hemostasis, try to stop the bleed and assess him properly. He would have lived. But someone who is bleeding, it could take you a few minutes to maybe an hour to lose that precious 1 hour window to save a life. And I'm looking at his injuries and I'm like, I wish he had the accident at Cape Coast Teaching Hospital around that place. Probably I would have been able to sort his problem, but I'm not God and I don't know. But I think that he could have been saved. He could have been saved because from police hospital to Ridge, where they also said there's no bed space, and we know at the emergency that we escalate to stretchers. It's not every time that you have a bed available. At Cape Coast Teaching Hospital, our bed capacity is 15. It's 15 at the emergency, but we can expand to 30 using stretchers and other things, depending on the situation at hand. But we don't turn away anybody. And you know that central region, of course, there are Okada riders. Pragya is now very popular in Cape Coast. We don't turn away an emergency, an accident victim. So it was really surprising for me to hear that an accident victim has been, turned away. Turned away to where? We are the health workers that are supposed to save lives. Are you turning the person away back to the street? Why? So I asked myself so many questions. And I know that, for us, it should be, for us, we should try as much as possible. We know that it is not perfect. The system is not perfect. We have seen the statistics. The system is not perfect, but our life, humanity should be very important to us as health workers, so that even if you try your best to save the person and the systemic failures don't allow you, at least you have tried. You have tried. But to just turn away somebody because maybe I don't have this, or the person on duty does not have the expertise to handle such emergencies, it is not right. That is what I have to say about this.
At the Cape Coast Teaching Hospital, is this incident that happened to your brother something you are all too familiar with?
No, we are not familiar with this incident. Over there, we do not turn away anybody. And if you have your bed, you don't have a bed space for a patient, your duty is to call. I don't have any right to turn away anybody. Your duty is to call the person superior to you, the specialist on duty, the head of department, and they will try as much as possible to get a bed space. so that you can, but your duty is to stabilize wherever you get, stabilize your patient. And over there, even the referral system is not so good in the central region. You may meet people coming in without calling, others to call. But when they come and it is still critical, we keep you and triage you. Even the referral phone at Cape Coast Teaching Hospital is handled by the doctor on duty. And you are obliged to pick that call at every point in time. And there are sanctions there. If you do not pick the call, you may lose some days off, or you have to do a presentation on something. So everybody's alert to pick that referral call. And you have the traffic control. If you can give someone from a referral facility, do this, do that, and then I can secure bed space for you. Your time duration to get to me is 2 hours. What can you do at your side and then on your way? The ambulance people, what can they do before the patient gets to me? So the patient doesn't come in a terrible condition that I am running around. So these are some of the things. It is not easy anyway. We also struggle, but we try our best. We don't turn away anybody, whether motor rider, whether pragya, or whatever accident. We don't turn away anybody.
Thank you for speaking to us at such a difficult time. Your story is a painful reminder of what delayed emergency care can mean for ordinary families. Well, let's now come into the studio and introduce my guests once again to you, as I introduced them to you earlier. And the key question we're asking this evening is, what really can we do to solve this problem? Dr. Grace Ayensu Dankwa is the Deputy Health Minister. Dr. Kwame Sapone-Siedu is a Democracy and Development Fellow with CDD. Perpetua Ofori-Ampofo is the President at the Ghana Registered Nurses and Midwives Association. Dr. Joseph Boni is an emergency medicine specialist as well. Ladies and gentlemen, thank you very much for your time this evening. Minister, I want to begin with you because obviously ladies first. You've listened to the harrowing story of Matilda, who sadly lost her brother, who, due to a lack of an emergency care, passed away. What do you make of that, briefly?
Thank you. And first, I would like to express my sincere, heartfelt condolences to Matilda. I've actually met her. She's an emergency room physician like myself. I'm a trauma surgeon. And we have spoken about, circumstances, and I know what she does in Cape Coast Teaching Hospital because I do teach medical students in Cape Coast Teaching Hospital. And so, like she said, something like that could never happen there. So, again, Matilda, we are really, really sorry, and we empathize with you and the family. Our heartfelt condolences. The incident that happened, I think it's a microcosm of what is a global issue that happened. I mean, this is actually not the first time that something like this has happened in Ghana. So this issue has a lot of, I believe it has a lot of tentacles. When you talk about emergency care, I usually break it into 3 different categories. The first category is the pre-hospital care. And the pre-hospital care is even more important than the hospital care itself. Because in trauma, we have something called the golden hour. That is the first hour of injury, the time of the injury to the first 60 minutes of that injury. Decisions we make during that golden hour would determine whether the person lives or dies. So certain decisions are supposed to be made in the first hour. And in this case, you see that a lot of the issues were missed during that first golden hour. Then you go to the hospital. When they got to the hospital, so the pre-hospital starts with, the information to even get the paramedics there. But for this particular case, they were so lucky that the paramedics the ambulance was close to the site of injury, of the accident. Then the next thing is there's a communication across the country, there's a communication issue. Then the ambulance itself. You know, how soon does it get there? Who is in the ambulance, the staff of the ambulance itself? What kind of categories of staff do we have in the ambulance? Then the third question is, this is all pre-hospital. The third question is, when the staff gets there, what capacity do they have? Are they able to do CPR? Are they able to start IVs? Are they able to give oxygen? There's different trainings and different categories. In Ghana, we have the different categories, which is, I believe, the basic, intermediate, and advanced. So depending on the configuration of who's in the ambulance, you might get 2 basics or 2 intermediary or 1 advanced. We don't have a lot of paramedics. I think we have about only 8 paramedics in the whole country. So that's also a huge issue. Then once the ambulance gets to the patient, or the staff in the ambulance gets to the patient, what do? Are they able, in this case, are they able to really stop bleeding, meaning packing the wound and stopping the bleeding, or just putting bandage or plaster or gauze on it? So there's certain things that should happen in the first hour. And even the first hour in trauma, we usually break it into 3. So the first 20, 30 minutes is the most important time, and those decisions will influence what happens at the end. So the ambulance picks the patient up. What do? Well, elsewhere, you see people doing, even having defibrillators to shock the person's heart on site, not even before they put the person in the ambulance. Then you bring the person into the ambulance. Then there's certain things should happen within the ambulance, from where the ambulance picks the person up and where they drop the person off. Here in Ghana, what we do is we call scoop and run. So you scoop, you stabilize to the best of, depending on the ability of the ambulance staff, and then you run to the hospital. But there's other interventions that could be done in ambulances. Some ambulances, when you have an advanced ambulance, you can really do a lot of interventions inside the ambulance. Then they get to the hospital. You saw the first hospital. There's also an attitudinal component of it. So as much as maybe they were stressed or tired, at least they should have stabilized. Because, I mean, it is part of our job. We swear an oath, and it's the Hippocratic oath, and that says, first do no harm. So that means that at all times, even if I wasn't in the hospital and I was outside tending to my children, and I saw someone with an accident or having an injury next to me, I'm obligated as a healthcare professional to help that person. So it doesn't have to be even just in a hospital. So that first hospital, apparently nothing happened. Second hospital, third hospital, and then you all saw the outcome. So, of course, the ministry itself is has had a committee that is looking into the issue. I believe the committee is almost done, so soon, maybe after the holidays, we will get the full report as to the real details and the circumstances, as Matilda has alluded to some of the issues. So currently we don't have that. I don't have access to that full report, but we will have it soon. But just from the medical point of view, there's a lot of things that happen. So I break it up into systemic, attitudinal, and communication. And inside the hospital, even if there was no bed in the hospital itself, staff from the hospital could have gone into the ambulance. The ambulance stretcher itself could be used as a bed. Technically, it is a bed. So it could have been wheeled into the triage area, and the patient could have been triaged. So looking at everything else, there's a lot of issues, some of which is systemic, right. Some of which, again, is attitudinal, and some of which is communication. Because we need to have systems where the ambulance can actually communicate with the hospitals. You know, elsewhere, which is what we are now. The Ministry of Health is actually piloting a program similar to that, where all the teaching hospitals will have a dashboard where you can see all the beds availability in all the major hospitals. There should be what we call a bed management person. elsewhere in most hospitals, there's a person that all that person does is bed management. And bed management is actually a department of a hospital, where that individual is looking at real time how many beds are available in this hospital, how many emergency room beds, how many beds in, let's say, in neurosurgery, how many ICU beds do we have, how many beds do we have in the maternity?
Right.
So, and this is a real time, a person who is on their feet walking around the hospital, collecting this information to a central point. So at all time T, we know how many beds are in this particular hospital. That information is fed to the emergency room feeds that information to that central bed management system, or nationwide or community-wide or district-wise, as we would probably have it in Ghana, or nationwide. So that information is, so the ambulance knows when it picks up a patient what hospital to go to. It can tell you, no, do not bypass Ridge and go to 37, because 37 has 2 emergency beds that are available. And see, it's not just the emergency room itself. So after the patient is triaged and the patient is treated, there has to be an emergency room turnover as well. How quickly do we move those patients that have already been treated out of the emergency room to free an emergency room bed? But that means that some of the patient will have to go to the ICU, some will have to go to maternity, some will have to go to orthopedics. So all that is like bed management, and it's a huge field of medicine that people actually like go to school to learn how to manage beds in hospitals. And technology is a huge point of it. So I think that in this situation, moving forward and looking forward, technology would be something that can help us, both technology with the ambulance, because I do know that the ambulance has a pre-hospital information management system. Currently we do. Now, if we have a hospital information management system, I think that the two of them can be interconnected, and we can share all that information, so that once an ambulance picks a person, first is the proximity to the hospital. If the hospital is too far, you're probably better off stopping at a nearer hospital, because remember that golden hour is the golden hour. So if you can go to a nearer hospital to stabilize, and then bring the patient back to the hospital that maybe has the bed that can transfer the patient. But I think in all of this, there's an issue of bed management, and it is not necessarily the physical bed itself, but it is the staff. That is, when the bed is in the emergency room, it is not just a physical bed. It's got to be connected to oxygen. It has to be connected to certain valves. It has to have a suction. It has to have certain things. So you just don't bring a bed just because it's a bed. And then you have to have the staff to manage that patient in that particular bed. So if you're on that shift, you don't have enough nurses or you don't have enough doctors, a couple extra beds will not really solve the problem. So it is management, bed management, human resource issue. It has to do with equipment, and also the bigger problem that I see is the backlog or the pressure that we put on our tertiary institutions. Because let's say our district to the sub-district levels are not really well resourced, we end up pushing everything into the tertiary hospitals, like the teaching hospitals. So they are really backed up with a lot of backlog. And so this kind of picture that you see, where perhaps the health workers in the emergency room were so overwhelmed anyway, so an extra patient they wouldn't go out to see an extra patient. So some of the solutions to this problem is our free primary health care. If we are able to resource the CHIPS compounds, the health centers, up to the polyclinics, people should be able to obtain healthcare at that level to reduce the pressure on the district hospitals as well as the teaching hospitals. When that happens, I think that the system will decompress a little bit, breathe a little bit, and then the technology can support us. The attitudinal changes has to do with retraining, in-service training, using technology to also remind people, to keep constantly reminding us that above all things, we are healthcare workers.
Right.
And as Matilda had alluded to, there should be no reason and no way that any patient should be refused,
Right.
no matter how the patient arrived at the hospital.
Right.
Even if they arrived on a aboboya or a bicycle, we still had to take care of that patient,
Right.
because that patient was bleeding to death. And as you saw, they exsanguinated to death, and
Right.
that is unacceptable in medicine.
Minister, I'll come back to you later. Let me come to Dr. Sapone Siedu. Dr. Matilda Amisa did mention that at the Cape Coast Emergency Unit, they have 15 beds, but they can expand it on several occasions to accommodate more emergency cases. Why are the other teaching hospitals not able to do the same?
They all do.
Thanks. I think most of the teaching hospitals and most of the hospitals have acknowledged that they do same. In fact, if my memory serves me right, recently there was an incident in Kolebu where they said that people were being treated on the floor and in chairs and all that. So there's evidence that the hospitals are doing same. But for me, the bigger picture is the flow into those emergency rooms. You see, emergencies don't just happen. Emergencies happen because things didn't go properly. So, for example, an accident could happen, which is an act of God. It's a fluke, and you cannot do anything about it. But many other accidents would happen, which are due to negligence, either on the part of the person or the part of another person. And then there are other things that happen in healthcare delivery, for example, strokes and all other things, which would also happen, which would take people to the emergency. So there's so much to be said about decreasing the flow of traffic to that emergency room, which is not happening. So if we talk always about expanding the capacity, because we can expand the capacity without decreasing the flow into that place, then the pressure on the health professionals in that facility would not be addressed, like Grace said and Matilda said earlier. So we need to also be thinking about what we can do to decrease that pressure. There are a number of things. I was giving an example earlier where a motor has an accident. The person is badly injured, or this hit and run unfortunate incident. Someone is driving negligently and runs over someone on a motorbike. Till date, we've not found a driver. How do we ensure that those people are apprehended so those accidents do not happen? There are CCTVs around. Do we monitor them? So, for example, if such an accident has happened, is there the possibility of the police monitoring the CCTV and looking at each junction that said motorcycle or that car, whatever, crossed? Were they police officers? At that time, were they riding or driving recklessly? Were they stopped? You see, because if we continue this thing, and like I always say, I have conversations with Dr. Bonnie and I tell them that we talk about no bed syndrome. A syndrome is a culmination of a number of activities, and therefore there are underlying conditions. So if we don't manage the underlying conditions and we continue to treat the symptoms, then we would continue shouting. And that is the reality we are not dealing with. We have managed this whole no bed process for as long as I've been part of the conversation, over 10 years, as a symptomatic treatment. Someone dies, let's get beds, let's get oxygen, let's get defibrillators, let's get this, let's get that. Good. But why are we not preventing the progression into that emergency services? And for me, that is the bigger conversation that we need to have.
Right. Madam Perpetua, I would come to you at this point. What do you think is the root cause of this emergency healthcare crisis that we are witnessing in this country?
In fact, I will take it from the data you shared at the beginning. And before I go any further, I want to express my sincerest condolence to Matilda and her family. And not just Matilda and the family, but everybody who has lost a life at any emergency center in Ghana. And the truth of the matter is people are dying every day. Every day, as we sit here, people are losing their lives at our emergency centers.
That are preventable, right?
Most of them are preventable. But the core of it all is the decades of our inability as a country to properly invest in health, to build a health system that is responsive to the needs of its people. We've grown in terms of population. We have the number of cars on our roads have increased. Today, a lot of motorbikes are on our road, including Pradgia. Our roads are not expanded, and therefore we are all using the limited road access that we have. And a lot of people are selling in the streets. So many things are happening. And so the health system we have now and the infrastructure and everything is not responsive to the current issue. Let me just, you talked about 5 teaching hospitals. In fact, we have 6. Now, if you take, let me say, Kolebu Teaching Hospital, 50-bed capacity at the emergency. If you talk about Police Hospital, 10. UGMC, about 20. Cath, that's Conventional Teaching Hospital, 35 beds. And we have heard from Matilda, Cape Coast Teaching Hospital, 15. In fact, they would all stretch themselves to accommodate at any point in time. But the truth of the matter is, with population growth and all of that, how are we responding to emergencies within our countries? And in fact, including disasters and all of those things. So if at this stage in 2026, we had even emergency and critical centers in all our regions, it should have been a plus for Ghana, but we don't have them. Emergencies are situated in hospitals that are already in existence, and these are just small units. They are not big enough. Our ambulance systems are not really strong. Referral gatekeeper systems are not really working. Lack of coordination. And then you come to human resource capacity. Yes, we don't have enough of doctors. We have enough of nurses. We are not able to recruit. I'll go into that. But those that are specialized in emergency care, we are thankful. Our Honorable Deputy Minister is an emergency care specialist, trauma. But how many of them do we have in our country? How many doctors? And then you talk about nurses. How many emergency or critical nurses do we have? Most of them, as we speak, have traveled abroad. And we have limited numbers in our system to take care of us. When you go into the facilities, what do we find? Even the small units we have in our hospitals, it doesn't also have the capacity in terms of the equipment we need, the specialists and the beds and all of those things. So it continuously creates huge gaps in our system. So what we actually need to do is we must have a strong emergency governance framework and probably have an emergency authority. Yes, a lot of things have happened in the past. These things happen, we create committees, technical committees or investigative committees. They come back with the reports. Then we do reactionary approaches, provide beds, provide this, provide that. And then we talk and talk and talk. And what happens? The conversation dies down until a more prominent person loses their life, then we start the conversation again. But in between the prominent people who die, a lot of Ghanaians also lose their lives that could have been saved. So if we have such an authority and then they have oversight responsibility, because without governance, we cannot actually drive emergency health care. Aside that, the pre-hospital care, which we all note that it is very, very important, and that is the whole ambulance system. We need to build it and build it well. Who is inside that ambulance providing the care? It shouldn't be just the emergency medical technician. We should even have some specialists and have the defibrillators and all other gadgets that can actually save lives. But those that we have are inadequate. When we talk about emergency units, I think I've mentioned this. By this time, Ghana should have emergency centers for emergencies only, not hospitals with the emergency units. So even with the units, we still have to strengthen them, but we must have emergency centers. We must also invest in the human resource that we have. And the lack of trauma specialists, lack of nurse specialists in emergency care and critical care is something that we have to actually look at and develop the infrastructure, ensure sustainable financing. If you look at the history of financing of health, and you showed it in your earlier data, the fact that you indicated that about 60, we did 22.8 billion this year, or last year, 2025.
Yeah.
And out of that, 65.9 went into salaries, 34.1 into other things. That was what you shared. So is this enough? If we are having 34.1% of this to cater for the infrastructure, the equipment we need, and everything, is it adequate? Year after year, decades after decades, we are still talking about no bed syndrome. Somewhere 2012, when the population shot up, we realized that our systems couldn't hold it. It was somewhere around, I think, 2017, 2018, that the no bed syndrome thing came into our conversations, and we started using it till date. But the point is that we haven't financed health adequately. And if you check, you realize that we've been doing somewhere around 5%, 6%, 7% of the total budget, national budget, targeted towards health. We are not meeting even the 15% Abuja Declaration that most of our countries actually signed on. So it's not adequate. If you look at it just merely by the way you looked at it, just health, then you may think that, okay, maybe a chunk of it is going into salaries, so there's not enough. But the salaries that are being paid, even with that one, is it adequate? We know it's not adequate. It's not taking people home. But at the same time, we need more to actually build the health system. Data, surveillance, and all of those things actually need to be made now with AI and with digital tools around. And you see, our problem is others have done it. All we need to do is go and copy the template and even use it. And we are not even able to copy. We should be able to copy and do it well to meet our own needs, you know. And we need to also educate our people about how to access care. We spend a lot of time on television with shows and so many things that does not actually bring anything to us as a people. We should spend time educating our people on preventive health care so that we can prevent a lot of things from even happening in the first place. And then we can save our finances towards other things. But I'm saying this because we know galamsey is on the rise. Even as I sit here, we run a health fund in the association, and the kind of conditions our nurses, our own nurses are having, communicable and non-communicable diseases, are rising. And it is the same within the population. And preventive health care is one area that we need to strengthen. Now, if you look at the system from the CHIP compounds to the health center, to the district hospital, to the regional hospital and all of that, people choose not to go to those lower levels, all because they know with lived experience that if I go there, I might not get a proper doctor who may take care of me. So why don't I save my time and energy and go to the bigger place where I can get probably all the care I need, you know? So people bypass the referral systems and also seek care in these areas. And that is what contributes to the patient load, which is on the rise, and it is increasing every time. In emergency situations, I think Deputy Minister has talked about a lot of things, so I don't want to go there, but we need to be able to actually follow all those systems. And let me say that it's a no-bed syndrome. It's an emergency crisis, but truthfully, it's a public health crisis.
Yeah, it is.
It is. And we must sit as a nation. I was expecting that by now, the Ministry of Health should have invited stakeholders. We should be sitting down. I know that the technical committee is working. They are done, the committee you mentioned about. Okay. Okay. Well,
I'll give you enough time to explain.
What I want to say is that you see, this is a time. Charles' death should bring us lasting solution. We must sit down and solve this once and for all. We should be tired of the talking and begin to implement things that will bring solution to our problems. And that is the way we have to go. And the bit about quality assurance and accountability and all of those things factored in, I'm sure if it is you get the care you need. And if it's me, I should get the care that I need. Nobody should be turned away in any emergency situation. And I can say that our health workers are overstretched. They are doing their best, but the system is not supporting it. And we shouldn't at any point in time hold anybody responsible for the death of a patient.
I tell you what, I do agree with you perfectly that we actually have a public health crisis because there's a CHIPS compound that I visited not long ago. They did not have water. So what happens is that the health professionals themselves carry water from their homes and, fuel the facility with their own water that they carry, or sometimes they buy water from across the street so that it powers the facility. So it's quite serious, very, very serious. But I'll come back to you once again. Dr. Bonnie, let me come to you. Now we've been made aware that the issue goes beyond beds, availability of beds. And the critical question is, how did we get here? How are we facing multiple issues from different fronts at the same time?
All right, thank you very much. And my condolences goes to the family of Charles. I received the message of him being missing through the emergency medicine platforms that day, and I sent it off only to be able to put the dots together when the story broke out. So it's quite heartbreaking for us to know that our own colleague has lost a relative due to emergency systems that couldn't line up to provide the care. The one thing I would like to point out clearly is that we seem to be missing an entire group in these discussions, and our emergency medicine medical technicians, the EMTs who work on the National Ambulance Service, are huge stakeholders to these conversations, and we're hoping that in other platforms, they will be here to also be able to speak about the great work that they're doing as part of building emergency care. So in 2017, we looked at the flow of patients in Komfo Teaching Hospital. We looked at where the bottlenecks could come from, and we prescribed some solutions. Years down the line, these solutions are still visible as the possible ways to make this happen. And it was in 2017 that in a presentation, we coined the term no bed syndrome, showing that it had various components that came together. So at some point, I probably should file a patent and get 50 pesos for every time someone uses the term. But Ghana in 2023 did sign a WHO resolution stating that integrated emergency, critical and operative care for universal health coverage and protection for emergencies. Ghana has already committed to this, along with a stock of other policies that we have committed to this. These policies are supposed to be the guiding principles for the healthcare that we provide. And coming this year, we will be going back to sign another policy that will be looking at the development of the global strategies and action points for this integrated emergency, critical, and operative care, which is supposed to be from 2026 all the way to 2035. Are we able to say that as a country we can achieve what we have signed up for? Do we have the capacity to say this? I would speak about two theories quite quickly. We talked about Cape Coast Teaching Hospital saying they can stretch up to their limit. Madame Perpetua mentioned 35 beds in our emergency department. I think I can add 2. We will have about 37. But at some point, we're stretched the capacity of seeing over 100 patients in that emergency department. We are considering healthcare as entering the hospital. That is not the totality of healthcare. Being able to enter an emergency department does not guarantee healthcare.
Right.
If you are in an overcrowded emergency department, which cannot provide the adequate care you need or the continuous care that you need to receive over the duration of your hospital period, you are not receiving the health care you are entitled to as a Ghanaian. It is your right to receive that level of health care. So 2 theories I'll speak about. The first one will be the queuing theory. And this says that if your system is always at a maximum capacity, if you are operating at 100% all the time, and in this case, both Cape Coast Teaching Hospital's example and Komfo Teaching Hospital example is at 300%. It means that you have no buffer for predictable events. So these are predictable events. There will be some road crash. There will be some patients that will get injured. There'll be people that will be involved in one accident or the other. And you can always predict that these will happen. But what happens to the unpredictable events where it is above and beyond what you can handle? You're already at 100% capacity. What happens when they bring in 7 patients from a building collapse? What happens when they bring in 10 patients from a church that was on fire? You're unable to manage this with the staffing, with the space, with the equipment, if you did have equipment, and with the healthcare workers who are already working tirelessly to make this possible. It takes me to my next theory, which will be the Swiss cheese model. And if we have the image of a cheese that has the holes in it, it means that you will always have a set of conditions that will lead to patient harm. Until you have a lot of these aligning for the spaces to be equal, you would not have harm to the patient. And the last of this model is the healthcare worker. And unfortunately, as the healthcare worker continues to innovate and find ways out of their scope to be able to help a patient, they are still the ones that interface with your patients. They are the ones that bear the brunt of you didn't do enough or you haven't done enough, whilst you are missing the organizational structure, the funding and resources, the technical systems that should be there, and teams that are supposed to support that emergency physician at the space, that pre-hospital care provider there, that emergency nurse who is alone in a district and is the only one that is standing between emergencies and the patients that are seen. Our tiered healthcare system is brilliant, and we probably have one of the nicest tiers of healthcare systems in a lot of places on the African continent. But unfortunately, these tier healthcare systems have not been based on capacity. And whenever they have been based on capacity, they have not been renewed. A hospital can only manage neurosurgical cases in the presence of a neurosurgeon. This update of information is not a 2-yearly review. The day the neurosurgeon travels for the weekend, that hospital should be classified as not being able to manage neurosurgical cases. And Honorable Deputy Minister will side with me, and she's seen it in other places where you're forced to divert patients if one person in your staff, critical person, is not in that space. So we're looking at a lot of policies that needs to be developed and go on to support the service provision. But these policies cannot sit and hang. So why can't we start thinking about someone that owns these policies, sits every day, this is their 8 to 5 job, moves them around, moves into service provision, moves into healthcare training, a desk at the Ministry of Health that is specified for emergency care. Because we're going to have this beautiful system coming up. That is going to be our bed management system. Who is responsible for this? Who is managing this? What is the capacity of this person managing this? And viewing such a command center in Abu Dhabi just in December, it clearly shows the intergovernmental relationships there. But the person managing this, and we're not marketing for ourselves, is an emergency physician. And that person has a scope of everything that is happening. And once the patient details are entered in there, it shows them which hospitals have the capacity, not the closest, the capacity to be able to manage the patient, and what resources we can have. And if those are exceeded, where those patients can be diverted to. So it's really a system that we need to try and put together. And at some point, I'll speak a lot more about the training and attitudinal aspects of the healthcare worker.
We will surely get to that. You're still watching the JoyNews National Dialogue on Ghana's emergency care crisis. We're also live on Joy 99.7 FM, live across our numerous affiliates as well. We're also live on social media, Facebook, X, Instagram, and YouTube. Let me acknowledge the presence of guests who are joining us via Zoom. The Deputy Director at Komfanoche Teaching Hospital, Dr. Yao Opare-Labi. Dr. Dario Sosai is a former CEO of the University of Ghana Medical Center, otherwise known as UGMC. And Dr. Winfred Ba is the Registrar of Health Facilities Regulatory Agency, also known as HEFRA, and Dr. Levi Ankra is the Vice President of the Kolebu Doctors Association. They are all on Zoom, ready to speak to us. We'll take a quick break. When we return, the conversation continues. You're welcome back. You're still watching the JoyNews National Dialogue on Ghana's emergency healthcare crisis. We have an additional guest joining us in the studio, Dr. Winfred Ba. He's the registrar at HEFRA. Dr. Ba, welcome to the program.
Thank you.
Right. We've had quite a lengthy conversation while you were away. I want to pick your thought briefly on the emergency care crisis that we have in our country. And in fact, we're getting to know that it is not just an emergency healthcare crisis, it is a public healthcare crisis that has rippled the country's healthcare system.
Yeah, thank you very much. And let me say my condolences to Mr. Charles Emisa and the family. I think I've listened to our guests and they gave very brilliant submissions. I think that's probably the only link now to see how regulation also comes into play to make all this work. I've looked at the number of licensed facilities we have in the country, I mean the government facilities. We have about 2,100 emergency beds all over the country. But that falls short of the WHO criteria. So ideally, we are supposed to have about, with our population, we should have about 4,320 beds. So we are, when it comes to emergency beds, we are operating at half capacity or so. But this is just government facilities. So for me, what else can we do? I think we should bring in the private facilities when it comes to managing our emergency care. And I was asking myself that if our brother was picked at a circle, could he have just been driven to the nearest private hospital? But how would the ambulance crew knew? That's why the emergency care, the digital system will help. So they can tell, okay, maybe you can go to Nyaho, there are 2 or 3 emergency beds there available. And there is the manpower there, they have specialists there. Or you could have gone to maybe, I don't want to be mentioning it, but the nearest private hospital. So I think, to start with, our emergency bed is short with about half.
Right.
So I think we should be able to bring the private hospitals on board. And I think this centralized emergency bed management system should add the private facilities, especially those that are a bit more advanced, to handle some of these things. Something like suturing, it shouldn't be in Kolebu, taking up beds. Kolebu should be receiving people with head trauma. Because head trauma in Ghana now, you can only go to Kolebu, Ridge, maybe UGMC, and 37, and then Komfanoche. So why should you let a simple suture go and occupy a bed there where more advanced things are there? So I think these are the things we have to look at.
Right.
It's not just the absolute number of beds, but how we utilize the beds. And as regulators, we also think, and we've talked about the bed management, bed bureau management. From this year, we as regulators are going to make it mandatory. Before you renew your license, for every hospital, especially from the primary to tertiary hospital, you must have a very effective bed bureau management system. Otherwise, we will not renew your license.
You mentioned about bringing in the private health facilities, but others have also raised the issue about cost.
Yes.
in assessing these private health facilities. How will that be looked into if you are to do that collaboration, the issue about cost?
Great.
Assessing private health facilities.
So we have proposals. One, the insurance that the cars pay, so the motor insurance, I think there should be a part that should cater for people, for example, these accident victims. There is no relative. When they are seen at any emergency, let's say if it's SIC insurance, they should be made to pay for that emergency. And I think that should be factored in the amount people pay for vehicle insurance. So that once an accident victim comes, whether it's treated at a private hospital or not, that insurance company must pay. The second thing is, can we get national health insurance to also cover for those who have been involved in, let's say, road traffic accidents, and there's nobody to take care of them? If a private hospital takes care of them, can we get NHIs to cover? But I think the best bet would be the insurance companies.
Yes. Minister, let me come to you. Where is the breakdown most severe, the breakdown of this health crisis that we have? Is it infrastructure, referral, transport, staffing, triage, or where?
I think it's all of the above. But I think that we have discussed the issues ad nauseum. So at this juncture, I think we need to look at solutions. As the doctor from HEFRA said, we have already piloted an emergency medical system, bed management system across the country. We're going to try to do, we're doing that in the teaching hospitals. Pretty soon the data will come out. We started this program even before this incident happened, so it's not after the incident. And we're waiting for the data so that we can escalate it to the rest of the referral hospitals. We have, in terms of just about streamlining the services, strengthening the services and streamlining it, so we are all on the same page in terms of how we manage emergencies. There are several documents that are already existing that we have reviewed it as a ministry. We have the implementation guideline for national patient referral policy. We have the national patient referral policy. We have the policy and guidelines for hospital accident and emergency services in Ghana. The gentleman mentioned the universal health coverage, towards universal health coverage, the WHO policies. So we have reviewed all those policies so that we can streamline emergency care so that everybody knows basically what they are supposed to do. But that means that we need to strengthen the base. And as I believe Kwame had said earlier, if everybody is going there, and as one of our panelists alluded to, we are already at 300% capacity.
Right.
Now, the goal is to reduce the 300 capacity of our referral hospitals. How do we do that? That is how the free primary health care comes in. When I say free primary health care, what we are trying, or the government is trying to do, or is going to do, which we will launch next month, is that anybody that accesses Ghana health care, from the CHIPS compound to the health center to the polyclinic, will enter that system for free. But more importantly, it is the preventative and promotive healthcare that we are introducing that would reduce the burden and reduce the pressure on the referral centers. We have also started sending doctors to district hospitals. If some districts don't even have, district hospitals don't even have physicians. And not only that in the big cities, but the disparity across the country is frightening.
Right.
Some regions like OT region, the doctor-patient ratio is just unbelievable. So we are trying to remove all those regional and district disparities by sending doctors, newly trained doctors, to the district hospitals.
But
I went to
Minister, but the interesting thing is these doctors are refusing posting in OT region and other parts of northern Ghana. They've been posted there. They say they will not work.
That is correct.
How do you intend to let the new ones that you are posting to these districts actually work there?
I just came back from Ahafo and Bono East just to meet those doctors, to find out what the issues. We spoke to the regional ministers there. We spoke to the MCs and the DCs there to support the doctors. Maybe they need a vehicle on the weekends. maybe it's about housing, maybe it's about water. How do we support these physicians to stay? Because when you get healthcare closer to where the people are, it will decrease this pressure on the teaching hospitals. It is what actually, if we are able to do this successfully, and if the doctors we're able to make them comfortable to go there, I think this will be one of the bigger solutions to this huge backlog problem. We have already started it. A lot of the places, I went to Bono East, they had 25 and almost 20 had already reported. When I went to Ahafo, it was less. We posted 23 and I believe only 8 had reported. So the 8 that didn't report, the rest that didn't report, we are going to replace them. So we will replace and push the doctors to the district hospital. If you can get your care closer to where you live, to your district hospital, it's a much better place to be than to have to troop all the way from Bono East to Ashanti region, to Kumasi, to Konfanochi, to get the needed health care that you need. So that is one other solution.
Is it not better to rearrange those who are refusing to go, in addition to the people who you are sending there to replace them, instead of flat out replacing them?
We have engaged those who have refused to go. Some of them are already working in private facilities.
Right.
Some of them have traveled outside the country. Those who we can convince to go, we have convinced to go. So we are actually doing better than before. But we still need to have these doctors in the district hospitals. Healthcare closer to the people is the solution to the problem. So once we have a universal document on how to manage emergencies in this country, and the doctors are actually at the district hospital, we have implemented free primary healthcare, and we are adding promotive and preventative healthcare. So people are now healthier. They don't have to wait till they get the diabetes and the high blood pressure and they have the kidney failure and they need the dialysis. In spite of that, once you have these complications of the chronic non-communicable diseases, we have also instituted Mahama Cares. And what is Mahama Cares? Mahama Cares is actually the Ghana Medical Trust Fund. It has put aside funds to support people who have these critical diseases, non-communicable diseases, because we found that 43% of all mortalities in Ghana is due to non-communicable diseases. So to reduce that non-communicable, that number, we had to do something about non-communicable diseases. Mahama Cares not only supports them with funds for their health services, it also is training doctors and nurses for those critical specialists that we need. Not only that, it's also doing research, and Mahama Cares is also doing retooling. Retooling meaning that we need more sophisticated machinery to take care of somebody who has a stroke. Well, if somebody is having a heart attack, you need a cardiac center. Currently, we are building 3 cardiac centers across the country, 1 in Tamale, 1 in Konfanochi, and 1 in Kwalebu. So we are actually thought of the problem holistically, and we are managing it, and we have also put systems in place to reduce this, so that this conversation is not all about talk again. I told you, I read the 2018, it's almost identical to the 2026 incident. So the talk is over. I truly believe that enough of the talk. Let's do, and let's see the action and see how best we can help people. Because as I always say, any one of us can end up there. Healthcare is for all. It is not partisan. It doesn't have any political color. It doesn't have any coloration. Any one of us could be that gentleman, Mr. Emisa, tomorrow. So let us all work together to fix the problem.
And Minister, I'll come back to you. Madam Perpetua, let me come to you. There are concerns most of the time about attitudinal problem of health professionals. Nurses, in particular, have been on the chopping board for quite a while. People say that most of the attitudes of most of our nurses at the hospitals are very bad, and these contribute to some of these preventable deaths. Have some of these concerns come to your attention? And if it has indeed, have you investigated them to find out the truth?
Well, I would say that it has come to our attention as an organization, a professional association and a trade union at that. We are partners in the health system. We work hand in hand with the Ministry of Health and its agencies, with the largest being the Ghana Health Service. The truth of the matter is that we form the largest of the health workforce as nurses and midwives. And interestingly, if somebody goes to the hospital and sees a female wearing scrubs or wearing, that person is a nurse.
They assume it's a nurse.
Yes, they assume it's a nurse. And when it's a male, it's a doctor. Even male nurses are referred to as doctors. And so when the bad comes out, we bear the brunt. But when it comes to emergency care, most of our health workers working in that setting are overstretched. They are overstretched to the point where I can conveniently say that sometimes decisions that may be taken or what needs to be done may not be done. But that is the more reason why we must improve the system to aid them to do what they need to do. So the blame issues and the attitudinal issues, we need our employers, which is the Ministry of Health and its agencies, to ensure that continuous professional education, new learning is at our grip at any point in time. Basic life support, advanced life support, in between, whatever it is that we need to get, everybody learns it at any point in time. When you go to certain countries, these defibrillators are even positioned along the roads, in boxes. If anything happens, pick it. Everybody is taught how to use it. Not only health workers. In our setting, things are different. But continuous education is very important. Building the capacity of the health worker, investing in the capacity of the health worker to make the person more resourceful. We continuously tell our nurses and midwives that, look, you may be overstretched. The workload may be too much. You are taking care, you are documenting, you are typing. Even somebody is using the computer, you have to wait, document, and then go and type in later. The workload is continuously increasing. But at the same time, you must always pause and understand that you are working with your fellow human beings.
Yeah.
And you must be truthful to them at any point in time. If somebody comes to the OPD and has to sit for long hours, we'll blame a nurse. But you must find a way of explaining to them that, yes, you are in a queue, the doctors are taking care, they are spending about 30 minutes with each patient or 20 minutes with each patient. So it's taking a long time. Have patience, it will soon be your turn. When it comes to emergencies and people, you know, in that vulnerable situation, people are expecting
miracles,
magic to happen.
Yeah.
And you don't want to lose your loved one. So already you are emotionally stretched. So we expect that if you are in an emergency setting, you must have a way of communicating with the patient's families to calm them down and also do your bit, what you need to do. Triaging is key. And you don't need to turn anybody away. We also know that if you are nursing a patient on a bench or in a wheelchair, it's unethical. It doesn't meet the standard. And patients must be nursed on their beds. Yes, my health worker colleague said, the stretcher can even be brought out and it serves as bed. When hospitals are expanding their units, they bring beds from other units and let it take up any space that is available, even on the corridors, within the units and everywhere. We must understand that our first major role is to take care of the patients. And therefore, no matter the situation, we have to do our very best. We must show our professionalism at any time. But at the same time, we need our employers and government as the overall employer to invest and ensure that we have the right systems in place. That is why I'm happy that Minister is talking about a stakeholder engagement that will happen soon, and that policies are being reviewed. That's the next review of all the policies that are available and all of those things. A digitized system of bed capacity and all of those things are also being rolled out. Some piloting is going on. We need to see these work and scaled up.
Right.
To ensure that nobody is turned away at any point in time. Let's not dwell too much on the attitudinal. You see, I've had certain conversations and we focus on the attitudes of the health worker without necessarily looking at the systems that have resulted in the attitude of the health worker. Look at the Kolebu case, for example. The nurses involved are staff nurses who have been working for just a minimum of 3 years. Have they had adequate training as is required to work in a heavy load emergency unit like Kolebu Teaching Hospital? Have they? Now, you come into a system where you also learn on the job. You learn on the job. So whatever you came to meet in terms of what your seniors are doing or the health team is doing, you run along with those. It may not be the best of it, but that is what you learn on the job. So you end up having to do certain things. But the bottom line of this whole conversation is that we don't want to see any Ghanaian, anybody living in Ghana, to be turned away from our health facilities. Our role of professionals is important. We must do our very best within the difficult situations we find ourselves. And Matilda shared hers. Yeah. And that is where we have to go. Everybody must play their role critically in such situations. And we have to get our employers also doing the needful by ensuring that the system is built in such a way that we do our best. Ghanaians move elsewhere and they are perfect health workers. Why can't we all be perfect in Ghana? Because the systems doesn't function properly. Retention packages are not there. We are not really well motivated to do what we need to do. But lives are more important than anything. And so far as you decide to continue working in any health facility, you must assume professionalism in anything that you do.
Perpetual Oforiampofo is the president of the Ghana Registered Nurses and Midwives Association. You're still watching the JoyNews National Dialogue on Ghana's emergency healthcare crisis. You, our viewer at home, can be a part of this conversation by calling us on 030-2211-691 or 0302-211-692. You can ask any of our guests a question, or you can share an experience of an emergency situation that you witnessed or somebody you know has witnessed. Let me come to you, Dr. Asiedu Sapong. The minister has mentioned a number of interventions that the government has put in place. She's mentioned Mahama Cares and other, healthcare interventions. The concern is that if these monies are pivoted to some of these policies, why don't we use these monies to rather improve the infrastructure, to rather employ more healthcare professionals within the healthcare system?
Thanks. You see, the problem with our healthcare system is known by all. And to start with, we're talking about health. So in everything, you've got to diagnose whatever is going on. We've got a number of reports. I keep referring to them. We have the Health Harmonization Assessment Report that came out in 2023. We have the Holistic Assessment of Health Program of Works. We have what you call the Demographic and Health Survey and all that. So when I get asked questions about why don't we do this instead of that, the diagnosis has been done. What we need to do for the health system is known based on the reports. And the reports are commissioned by the country. They are commissioned together with the WHO, Global Fund, and other things. So we don't even need to reinvent the wheel. And that's where your question doesn't really come in. And that's why what the minister was saying and what Dr. Ba was saying is important, because they are not saying anything different from what the Health Harmonization Assessment Report said we need to do for our health system. And if anyone tells me, and I've kicked back against this a number of times, that we need to build facilities, I ask them, was that the diagnosis of the Health Harmonization and Facilities Assessment Report? Because that assessed the facilities across the paste. Are you trying to say that commissioning a report that included academics from Ghana, professionals from abroad, practitioners, even civil society groups and other things to come to a conclusion is not fit for the diagnosis of what's happening in our health system? Then what's the essence of diagnosis? Because primarily, in every health system, the first thing you do is to diagnose the problem. It's like any disease and all that. So unless someone convinces me that the diagnosis of all those reports were wrong, and if they were wrong, then I have a big problem with how we even run this country. Because if we can get all these huge reports wrong, then we don't even deserve to be complaining about the health system. So in that sense, the diagnosis has been done, and what needs to be done has been spelled out in plain black and white. I'm happy the Deputy Minister said all these reports are being at desktop reviewed. And based on that, there's going to be then a blueprint of the way to move. I think that is the best approach. The talk and saying, oh, what if we did this, what we did that, is at the point when all these assessments of the health system are done. And that's why, again, I'll go to diagnosis. My colleague doctors who are here will tell you, to get to the actual diagnosis, they have a differential diagnosis, query this, query that, query that, and then they come to a conclusion. Now we have the conclusion, let's run with it. The question then becomes, why have we had these conclusions? Because some of these reports are 2023, some are 2024. Why have we had those reports and done nothing with them? And that's why I'm happy that a lot of the things that are being said that they started prior to these happening. Otherwise, we'll keep shouting. And you see, the biggest thing was what was said previously. When someone in the middle classes, unfortunately, goes down this route, this abominable route, as I call it, we all shout. And like Dr. Bonnie said, on this occasion, the shouting has gone more than 10 days. It's normally up to 10 days. And then it's gone up to a month. We shout. But the truth of the matter is, people perish in the peri-urban and rural areas daily down this route. And we, the middle classes who, when it affects us, shout the most, keep quiet. That is the biggest scandal we have to deal with. And that is why when it's said that, oh, these things are being piloted and it's going on in like the rural areas and other things, I'm happy. Because health in itself, apart from being a science, is a social event. The closer you are to your environment, the better your outcomes. Whether it's even the most dangerous emergency. And we know all these things. I mean, I've got all the reports on my phone. I've been looking at them. I've been speaking to them for God knows when. So I struggle with that sort of question when I'm asked that, what if we did that? Because the diagnoses have been done. Those were differentials. They didn't make it to the final diagnosis. So let's run with the diagnosis we have.
Dr. Bonnie, I want to come back to the attitudinal problem that Madam Perpetua addressed. It's a bit of concern because I'm getting feedback that people are much more concerned about that as well. But she's explained her bit to us. But have you also had any experience like that where nurses, first responders, have been accused of having attitudinal problems at these health facilities?
Right, thank you very much. Unfortunately, I think when we start with talking about the attitudinal problems, I will take it outside the hospital and take it to the patient and patient relatives. We have a notion that when people are coming into the hospital, they have a notion that if you are not pushy, you will not get care. With nothing happening, you're being abused, you're being heckled, the level of tonation of a language of the first person you meet when they are bringing in a relative does not even allow you to process your demeanor to be able to respond in a calm manner. Madame Perpetua has really laid down the attitudinal points. And she didn't lay it down just for nurses. The conditions that pertain in the hospital doesn't just reflect on nurses or doctors. It reflects on every single healthcare worker. When the conditions are not favorable, it makes it difficult. If a ward that is supposed to take care of 37 people, it's doing 100. It makes it very difficult for you to be able to organize yourself and do your public relation as clearly as you should. There's also a very clear difference between being firm as a healthcare worker to promote the health of the person and being rude. It's a thin line, and sometimes people see it the other way. If I am telling you to sit down because your condition requires that you should sit down or lie on the bed, that is not being rude. That is not an attitudinal problem. That is facilitating your healthcare. So that balance always needs to be struck. Definitely, we cannot say that every single healthcare worker would have a good attitude on every single day. There might be days, and we can apologize for those few mishaps. But when people are stretched to a point, it makes it difficult for them to be able to work in a system where there are not enough equipment, there are not enough systems, there are not enough supporting staff. It makes it difficult to take up that burden alone. And sometimes when that is being explained to relatives, it might not come out well. We run a system at the Confanoche Emergency where our triage nurses will make an announcement to our patients who are waiting. In the middle of a very cordial information, somebody screams from the back an insult. That makes it difficult. Confanoche has put in a step, and it's a brilliant achievement, where they have recorded a video which tells you how the emergency runs. It explains the triage system to you. It explains why you might wait longer if you don't have you are not as critically ill as the person. And this is continuously played at the waiting area. This is phenomenal, and I believe others should be looking at similar ones in various languages wherever they are. Training is the biggest component. When people get trained and become confident in receiving and managing emergencies, it calms them down when a patient is walking in because they've been trained to handle that kind of condition that is coming in. If I panic and you panic, if I'm panicking as a healthcare worker and the relatives are panicking and the patient is not well, that situation will not go well.
You feel most of them don't have enough training?
We might not have a lot of people who have had enough training, and I'll go through the various ones. There are about only 100 emergency physicians in the country, scattered around 25 hospitals. Among these 100 are some of them that have emerged as leaders in the healthcare service, some as deputy directors in Ghana Health Service, the CEO of the National Ambulance Service, people that run at the Ghana College of Physicians and Surgeons. They are leaders within this space. So as we had alluded at some points that we do have doctors in our ratio, but they're not clinicians on the ground. So those numbers tend to drop. But among these, you do not need to see an emergency medicine specialist to get emergency care. Emergency care can be provided at the chief's compound, at the primary hospital, at the secondary hospital. With this, there are programs that can help with the training. There were conversations about basic life support, advanced life support, but we also have the basic emergency care course, which was commissioned by the WHO, supported by the International Federation for Emergency Medicine and the International Red Cross. And in Ghana, we've already trained about 375 people in basic emergency care course, with 43 of them being trainers. And this spans not just, we actually have more nurses trained than doctors in these numbers that we mentioned, and including our EMTs, people from the National Ambulance Service. Why are we not promoting this? Why are we at 300 when Tanzania is at 5,000? Why are we having small numbers for training that takes 5 days if you do a standard training, or 2 days if you do a hybrid training? The Emergency Medicine Society of Ghana has been spearheading this. They need to be part of the stakeholder conversation. So whenever there are stakeholder conversations, let's bring the people that are on the ground on board. And I'm very happy the minister said that these will come up, and the Emergency Medicine Society will gladly be looking forward to their invitations to contribute as the people on the ground. We need to bring in the academics. After we've put in this brilliant system, what are the numbers that are coming out? What are the durations of delay? Who is studying this to tell us where the monitoring, evaluation, system fixing, learning, and improvement will come from? Researchers to be able to do this, and so on. We talked about the number of emergency beds, and it was nice for us to mention the number of emergency beds. The minute the patient is admitted for a specialty, if you come and you have an internal medicine problem, and we say you have been admitted for internal medicine, and you continue to remain on that emergency bed, it quickly transfers from being an emergency bed to being an inpatient bed. So when you say Confanoche at some point, and I'm using an arbitrary number, has 50 patients in the emergency unit, I might probably be able to tell you 3 of them are emergency patients. The rest of them belong to other specialties, but are still sitting in the emergency department because their wards are choked and the patient's flow is blocked.
That's quite revealing, that point.
Yes. So it is not a problem for the emergency departments anymore, but the specialty teams have all their patients sitting in the emergency department. So there's no flow. There's a backlog, there's burden within the emergency department, and these patients cannot move to the ward where the teams will continue to see, so they sit in the emergency. So it's interesting to me when you hear phrases of, I paid money to get a bed. Where did you get this from? Because the ward is full. I have an emergency patient. The only time we will get a bed is when a patient leaves the emergency, either when they are discharged, whether they are admitted to the main ward, or unfortunately, when they die. And that is the only time at which a bed should become available. So if you did come to the emergency department and you are truly happy to send a message to say, I don't know why you want to do that, to say you paid for a bed, it just meant that somebody that had to wait 2 hours waited 4 hours because of your unpatriotic attitude.
But if they paid for the bed, that means there was somebody who received that particular money. The person just weaponized a space.
I think when you create problems, people can take undue advantage of problems that have been created in the system. I'm not confirming this is happening, but in any system where you do create a chaotic attitude, there are people that might take advantage of those attitudes. And I can assure you that some of the people walking around the hospital posing as doctors and nurses do not even work in the hospital.
Right.
Be careful who you speak to and take hospital advice from whilst you're in the emergency department.
Let me come to Dr. Ba for a second. Dr. Ba, your point?
Yes, so I mean, just to add to what he said, so that's what so let's say they will say your emergency is full, but people will say, oh, if I call a big person or somebody, I will get a bed. And that is true. The truth is that there are beds on the ward. And that's why we think the bed management bureau is very important. Because trust me, if they say the emergency is full and you call me at Kolebu, I will get you a bed. Why? We'll go and search on the wards. Sometimes, even at the surgical department, they do duties on this. So sometimes, before their duty, they have beds. Maybe one ward has beds. Because they are not on duty, they have beds. A bedroom manager can even say that even if the medical ward is full, we can move some of those patients from the emergency to the medical ward until the medical ward is free. Then we transfer them back. So at any point in time, I can tell you there is a bed in the hospital.
Wow.
Let me buttress what you said.
Almost.
Bed occupancy has remained below 60%.
Right.
The bed occupancy, even though we don't have beds, the bed occupancy is below.
Is how many? 60.
Yes.
Below 60. So why are we often told that there is no bed?
That is why we're talking about the bed management system. The beds are there. But the emergency is choked because we are not turning over. We are now moving those who have to move out of the emergency room to clear the emergency room beds to bring more people because of that bed management system. There is nobody in the hospital that is only looking at the bed. This person is in the emergency room. Have we finished taking care of them? Why did they come? Stomach ache. We have given them some medicine. Now the stomach ache is better. Their vital signs are stable. So let's move that person to medical ward and free that bed. There are people in the emergency rooms that are full who are not supposed to be there, who should have moved to different wards. But because of that bed management, the turnover is not happening. That is why it looks like, that is why this problem is not necessarily a physical bed. It is about a bed management issue.
So whose fault is it then?
No, Kenneth, let me come in here. That's the other problem. I'm surprised you're surprised because the data the Deputy Minister gave is in the holistic assessment of health program of works, and it has been around 60% for at least the last reports I have seen. So if the journalists even don't know that 40% of our beds at any point in time are not occupied, and that's why when I hear the payment thing, and that's why I said sometimes I sound like a broken record, because I'm like, how come these things are put in plain sight, yet we don't know?
Now we're here, we can fix it.
Let me follow up with what Dr. Asedo is saying. This 40%, and I'm always looking at this in the lens of the health structuring. This 40% might mean that there are some district hospitals and regional hospitals that have space. But it could also mean that Komfo is still operating at 120%. And I'm happy that the Deputy Medical Director is online with us, and I'm sure he can throw a little more light into that systemic issue that he sees from his lens about this. But in my view, I think that when there are management systems that provide to tell you where there's a bed, it will be able to solve the problem. but will the bed have the capacity to be able to manage that patient? It's a critical question that we need to answer. Because we have done this before. We measured it. We found a huge gap between finding available beds and the demand. If people keep trooping into the teaching hospitals, which unfortunately have become a victim of their own success, it's how good they are that the public thinks that, let me bypass everybody and come to you. Can we change this narrative about our polyclinics? Can we change this narrative about our regional hospitals? Can we get people to believe in them? They are doing well. Will you go to them rather than skip them and come and join a long queue in a teaching hospital?
Dr. Bar, you earlier mentioned that you're piloting the bed management system to try and get rid of all these issues. When is it going to go across the entire teaching hospitals?
I think that our minister.
Our minister will have to.
Will answer that one.
We are piloting it actually in the teaching hospitals because we want to see the beds have to be coded. Remember, we have to have a dashboard, and on the dashboard, it's not just a bed, it has to be a number and a code. So the beds will be coded, and it is not just also like, I think the gentleman said that just because you have a bed and you've moved the person doesn't mean that you've moved. You have to know where that person is going and the capacity of the ward or intensive care where you're taking that person. So this thing is not just the dashboard and technology. It is technology aided by people on the ground. Just like Dr. Bass said, he would go to different wards and look for the beds. So we need elsewhere. When we talk about bed management in a hospital, there's individuals who have the clipboards, who have dashboards, who literally walk emergency rooms, walk the ICU, walk the step-down units, walk the women's ward, the men's ward, looking to really confirm certain things and feeding that information into the system. Because the movement is not just also another move in a bed. But for instance, somebody comes with a neurosurgical problem. They have been triaged in the emergency room. Now they have been treated and they are stable. That patient cannot go to if it's a male, you can't just put them in a male ward. You have to transfer them to the intensive care unit.
Right.
Now, that person is still in the ICU because we don't know how many beds are in the intensive care unit. And they're telling us intensive care unit is full. There's not individual even checking it. There's no bed management system to tell you how many beds are in the intensive care. When they go to the intensive care, they also need to make sure there's a neurosurgeon there.
So how effective has the pilot been so far?
So far, the pilot is really working very well, and we are hoping that once we finish the holidays and all these things, we may roll it out because we don't have that many teaching hospitals anyway.
So how long will that be?
Oh, I don't really have the specific timelines because we also have to give it time to work. When you start everything, if you don't give it time to work, you stand a chance of failure. But we had started it before this issue came up. So hopefully soon we will launch it.
Right.
The National Ambulance already has an ambulance information management system. So the two systems have to merge or
work together.
To work together, because the ambulance will also have to call the emergency room to see which of the emergency rooms have beds available and what kind of beds and what kind of physicians are there. There's more information. And this system is nothing new. It is, I trained in the US, and that is exactly the systems that we went through. I could get information from the ambulance before the patient came to the emergency room. They could tell me that this is a 24-year-old person who is involved in motor vehicle accident. He has internal bleeding. It must be in the abdomen. So sometimes we even make decisions based on that information to skip the casualty or the emergency room and go straight to theater and do a theater resuscitation, just based on the information I'm getting from the ambulance. So these kinds of systems, I think that we are in the right times, the right technology, as Madam Perpetua said, AI and all kinds of interesting technological assistance, that I think that this is actually the right time to implement everything that Kwame said he has been talking about for the last how many years, and all these documents that we have read ad nauseum, and all the policies, the WHO, universal healthcare, and everything. I think this is the right time in the history of the country to bring them all together, and all of us working together to really make sure that our emergency systems do not remain as they are today, I think that at some point it is not good for the country. So we will work hard. We'll meet all the stakeholders, and we'll get together and put together a policy that will really work across board so everybody knows. And if it has to be with the film that you said at the waiting area to inform the patients of what really transpires and how long the wait. Sometimes they can tell you your wait is like an hour. You know, your wait will be 30 minutes because this. When the patients are also informed, it also helps reduce the pressure. And once the promotive and preventative free primary health care kicks in, I think that we would decompress the referral hospitals and hopefully soon.
Soon, without a timeline.
Hopefully soon.
Soon without a timeline.
No, I'm saying soon, meaning towards the end of this year.
Let's hope so.
That our emergency, not just the bed management system is not what I'm talking about, the entirety of the problem, that soon we will have real solutions to our real problems.
We have 70,000 health professionals who are qualified to be employed within the various health facilities across the country.
Yes.
Most of them are at home.
Thank you.
What is the government doing about this? How do we solve that issue?
Interestingly, we just had a 3-day conference with all the heads of the health training institutions. We just finished yesterday, and these are some of the issues we discussed. We have over 70,000 health workers at home, and some of them together, it's both allied health and nurses and the totality of it. It is a huge backlog that we inherited, and governance is a continuum. So we are not here to make excuses or lamentations. So some of the things we have done, one, is that you know that because of the 43% of all mortalities in Ghana coming from chronic non-communicable diseases, we need to train specialist nurses. So currently the nursing institutions are now moving from diploma to degree programs. We have, in conjunction or collaboration with the Ghana Physicians, Surgeons and Ghana College of Surgeons and Physicians, which I'm a fellow of, are training specialist nurses. We have given scholarships to some of the nurses to even go and have their PhDs. Because remember, we will need them to also come and be trainers of the trainees. So, and then we have something called the Managed Migration Program, which, like I think you had alluded to it earlier, 13 countries are asking us to bring our nurses. So currently, we've advertised about taking a group of people to St. Kitts and Nevis. The president was here about a month ago, and they want us to bring them nurses. So the advertisement is out there. People will apply. We will interview them, and then we'll send some of them. A group have already gone to, I believe, Bahamas, and the next group will be going to Barbados. We have a lot of countries that are asking. And when our nurses go there, they bring back really good reviews. So we are training good nurses, because when they go out there, all the reviews we get are really good. So it is a way to remove the backlog. Unfortunately, we inherited it, but we have to do something about it. And that is one of the ways. And as I was looking online at the Ministry of Health portal just now, they are in the process of hiring nurses. It just we're in the process of hiring more nurses. So it is a problem. And for us to solve a problem of 70,000 health workers, we need to think outside the box. And one of these things, as the managed migration and also the critical care training with the Ghana Medical and Ghana Physicians, College of Physicians and
Ghana College of Nurses and Midwives.
Yes. No, we're talking about the graduate ones, the ones who are come back and teach, the PhDs. But your Ghana College of Nurses and Midwives is going to be the one that is also supporting us to train these nurses for specialist care, as well as those that we are taking out for the managed migration. So it is a problem, but again, we are tackling it to the best of our ability. So hopefully we will slowly phase out the backlog that we have. And yes, thank you.
Let's bring in Dr. Levi Ankra. He's the Vice President of the Kolebu Doctors Association. Dr. Ankra, grateful for your time this evening. You mentioned earlier to me that you are the emergency ward all day, and the issue about emergency healthcare in the country being at a crossroad. The crisis facing the industry has come to fore. You being there, what are some of the challenges that you face on a daily basis, really?
I'm so tired.
Well, thank you. I was actually in theater, not in the emergency room.
Right.
It's a slightly different place. But I work in the plastic surgery unit, so we do receive patients through the emergency room. So I do understand some of the problems that go on there. I think the first thing I want to say is that people should be aware that we are also human and we are not immune to these problems of the no bed. Very recently, I had a colleague who ended up at the emergency room and couldn't get a bed. So we are all involved, and doctors are as concerned as the patients themselves. It's like Madam Perpetual said, it's time for us to stop the talk and actually look at the solutions. And I think the Deputy Minister has also mentioned that they are looking at the solutions. It's a complex problem. It's not just an issue of a lack of physical beds. And I think everyone in the studio has pointed out the different issues. We need a national plan. Everybody must be involved. Like Dr. Bonnie said, it's interesting that this has gone beyond just 10 days and we are still talking about it, but it shouldn't be just talk. We should try and implement solutions. We should have clear strategies. I think I just want to point out two main areas. I think they've been mentioned, but the human resource. We need to develop the human resource. And I'll just talk on the issue of doctors. So I don't think we have a national policy with a clear plan that we want, say, this number of plastic surgeons in the next few years. We want this number of emergency physicians in the next few years. We want this number of cardiologists in a certain period of time. The training of these specialists has been sort of ad hoc. And we should have a national policy, a direction on how we want to achieve these targets. And we should have these targets listed. The other thing I need to talk about is the funding. There is a major problem with funding. And it's, first of all, a patient comes to the emergency room, everything is cash and carry. So it should be a policy that the expenses should be catered for in the first 24 hours. Sometimes the reason patients stay long in the emergency room, for example, somebody who is coming with a head injury, the person cannot afford to get a CT scan. This thing must be paid for. And we don't have a system which is funding emergency care within the first 48 hours, 24 hours. There's nothing on ground. Everything comes from the patient or the relative's pocket. Also, we have to look at the issue of the funding of just anyone on the ward. They raised the issue about the bed review, the issue being a bed management problem. And I beg to differ. Bed management is an issue, and it has to be dealt with. But there's more to this. We've got an issue of patients being discharged and still remaining on the ward. So you have a situation where you've got someone who's been catered for and cannot go home. And he's occupying a bed, but he's been officially discharged. So moving a patient from the emergency room to the ward becomes a problem because there is somebody occupying the bed. And unfortunately, we have a system where it sort of becomes almost like a prison. A patient stays on the ward till he pays his bills before he's discharged. there's also the other aspect of understanding that the inflow to the wards is not just coming from the emergency room. We have people coming in from the outpatient department. We have people coming in as scheduled patients for maybe a surgery. So the inflow, we seem to talk a lot about the emergency room and the fact that we couldn't move patients from the emergency room to the ward. But the wards themselves are occupied already because you've got inflow from other places. And so the bed management issue is a problem. The last thing I would say is, again, we always mention that there may be a bed on the ward. But, for example, a week ago, I had a situation where I had to move someone from the emergency room to my ward. But unfortunately, the only free bed in the ward was in a female ward. And this was a male patient. So again, physically or on the paper, there is a bed available on the ward or in the unit. But unfortunately, you can't admit a patient there. So it's a complex problem, and we need to find solutions to it.
Those are a myriad of issues you've outlined there, but thankfully we have the Deputy Health Minister here. If you could speak to her directly, which of these issues would you want her and the government to fix first?
All of the above.
Well, yeah, it's just been said, all of the above. We can't pick a single... So the problem that we've been having over a period of time is that an issue comes up, and then there's a lot of noise in the media. And then we find a simple solution to sort of ward it off. Dr. Sapon, I think that's his name, he mentioned that the solutions are on the table. We need to tackle this problem from multiple sides. We cannot just pick a single place and say, this is the first and foremost thing we must tackle. It has to be a holistic thing. If we really want to solve this problem, we have to tackle it from different angles.
Dr. Ankra, I'll come back to you. Don't go yet, but let me come back into the studio and speak to Madame Perpetua, who has signaled that she wants to make an input.
Yes, I wanted to, if I don't say this, my younger colleagues are not going to be happy with me. The point is that when it comes to the figure that has been thrown out here in this dialogue, I think what you shared, you mentioned 74,000, including everybody, those waiting to be employed. Or
yeah, I think it was a little above 77,000.
When it comes to nursing and midwifery, we churn out averagely about 18 to 20,000 every year. As we speak, we have the second batch of the 2020, that's the referral batch at home waiting for employment. We have the 2021 batch, we have the 2022 batch, we have the 2023 batch, we have the 2024 batch, and I must tell you the 2025 batch will soon finish. That will be about six cohorts, and that is over 100,000. That's over 100,000. The engagements we are having with these countries are good, but none of these countries are interested in those that do not have working experience. So they are interested in those that are already in the job, having the degrees and having the add-on specialties. Those are the ones that they are interested in. When they are hard up, they come for the diplomates, those who have the diploma degree. So you have diploma, but you've been working in a certain unit in the hospital for a very long time, so you have experience, like the critical areas or the emergency, or that kind of thing, and they will take you. But in the current situation that we have, because we are taking our nurses from the health facilities, we are creating huge gaps in terms of those that are experienced to mentor the new ones that we are recruiting and all of that. And if you look at the 2020 batch that were last employed, most of them had lost their skills because they had been sitting home for over 4 years. They are employed and they don't know, they've forgotten all their skills.
So what's the solution?
So the solution is going back to what we used to have, where you finish training, the longest you can stay at home is 1 month. You are posted to the job. The government may not have money to pay you. You can work for about 6 months, and then that was what used to happen. Then your salary starts coming. If we think that,
how do they survive on a 6-month period without salary?
They were dependent on their families. They were also some had savings from the allowances they had received during training. So they were able to move. But the ideal is that, of course, when you put somebody, you should start paying the person's salary. That's the ideal. Now, what I'm drawing at is that we are training numbers. We are not trained for export because the people who want either Barbados or Antigua or Bahamas or any of these countries are not interested in these ones. That is the more reason why I'm happy that at least now we are moving to the degree training. We can convert most of our schools. The post-basic training that we've recently also advertised. You should have worked for 1 year and then done your national service for 1 year, 2 years working experience, and then you can go into neuro nursing and all those ones are good. But the crash program of 1 year, we also have a problem with it because those basic programs should be a 2-year program. If we are crashing it into a 1-year program, it is also problematic because it has repercussions. Now, the recruitment that is going to happen now is also very good, but I'm wondering how many of these numbers are we going to be able to recruit? If we could take all the backlog and now start on a fresh note, that would have been wonderful. But I know that the response will be inadequate fiscal space to actually take them all on. But we cannot continue training and adding on to the numbers. That will be another crisis on its own. But I must say that we are not seeing this only in Ghana. Unfortunately, it's happening in so many countries across Africa. Recently, when I was coming from Zambia, at the airport, this young lady in one of the shops that I wanted to buy something from, she's qualified as a nurse for 3 years. So just like our Ghanaian colleagues, you cannot stay at home. You've been invested in by your family to go train, and now you are still at home. So they are doing all kinds of jobs. And she is a shop attendant just to while away the time and also get something going. So it's a huge problem, but I'm just drawing the point that when it comes to nursing and midwifery, we may have a huge crisis on our hands. Majority of these are the youth, and they are at home not having jobs to do and yet having the skills that is required. If these high-income countries can actually take them on, it will be very good for all of us so that they can have something doing. That was what I wanted to add on. Thank you very much.
I'll let the minister respond because I see that you're itching to respond. I'll let all of you respond, but let me give Dr. Ankra the benefit of doubt to also make an input in this particular conversation. Dr. Ankra, you've been listening to Madame Perpetua make the point that the health professionals who are at home and unemployed could actually be absorbed into the system and then perhaps later they be paid. Instead of trying to say that we are sending them to the Caribbeans and other countries for them to help them with the expertise. Is that something you agree with?
Well, in my time, it took quite a bit of time for us to be placed on the payroll. So we worked for a while, and nobody likes that. I can only speak for the doctors. If you've been in school for close to 7 years, and then your parents have been taking care of you for all this time, and now you've come out with a DR in front of your name, it's not very exciting to spend time on the ward, working long hours, and not get any remuneration for it. Unfortunately, the problem is because we are not planning for this. There are so many people in the medical school. We know the numbers that are churned out each year. We should have a plan for what's going to happen to them once they come out. And unfortunately, we are losing doctors. We are losing the young ones who are just finishing medical school. We are losing the ones who are just finishing house job. And we are even losing some of our specialists. So when it comes to the human resource and maintaining the resource, the brain drain is a real thing. And we need comprehensive solutions to solve this problem.
And still on the issue about the crisis within our health sector, the onus also, some say, should equally be on hospital administrators, hospital managers as well. While we wait for solutions, the numerous solutions that we are proffering here, while we wait for those solutions, what responsibility do you think that these hospital managers should bear to ensure that while we still wait for government to proffer these solutions, it keeps the place running?
Well, to a large extent, the administrators themselves are challenged. In all honesty, how much do we pay for healthcare? On a daily basis, we see people come into the largest teaching hospital in Ghana, the third largest hospital on the continent, and the largest in the sub-region. And I don't want to mention numbers, but if you look at how much is paid for a consultation fee, it's inadequate. So in an instance, the administrators have their hands tied because we are actually not paying the right amounts for healthcare. Dr. Sarpong has mentioned this a number of times on different programs, but if we really want to get the right things, we should actually begin to put our money where our mouth is. There is a lot that has to be done by way of funding and taking care of healthcare. And if we are able to provide the right resources, the hospitals will function well. We have the very good human resource, whether it's doctors, nurses, laboratory technicians, whatever you might see. We have top-notch in Ghana. So we need to invest more in the healthcare.
So if I get you correctly, what you're trying to say is that if the hospital administrators at this point are to intervene, it's going to make healthcare more expensive.
No, I'm not saying that it's going to make healthcare expensive, but healthcare is expensive. And so we need to put the right amounts of money in our healthcare. If people are paying 20 cedis as a consultation fee, in some instances, do you think that is adequate? The person is being seen by a doctor, a nurse, there is an air condition running in the place. We need to pay properly for healthcare. We need to invest properly in healthcare. And healthcare is expensive. There is also the part of preventive healthcare, which I think has been spoken of already. But we need to put a lot more in healthcare. And that's why it's a national dialogue.
Not long ago, we've heard of patients suing medical officers, medical practitioners, because they accuse them of negligence. Now the issue about accountability, health officials, health officers being held accountable for possible negligence has come to the fore. Do you think there needs to be some accountability mechanism put in place to hold health officials like yourself and your colleagues within the sector when things go wrong and they are supposed to be blamed for?
Accountability is not a new thing. Doctors have been sued from way before I was even born. Within this country, it's probably because the numbers of the population are increasing, awareness is there, so probably a lot more cases that come to light. But it has always existed. The same way the processes that investigate issues when they come up and the reprimands that are done have also existed. And they are still going on these days. So it's not like healthcare workers are not accountable. Yes, there are always some bad nuts within any group. And then there are also times when people make mistakes. I can't hold brief and I can't point to any one particular case because each case has its own circumstances around it. But we are always held accountable. And we as health workers also understand that we are not gods and there are things that we need to do. There's all continuous professional development that goes on each year where we learn we revise our ethics. So there are so many things that go on. We don't always have the chance to come out and talk about it.
Dr. Levy, thank you very much for your time this evening. Let's go into the telephone lines right now and speak to the Deputy Director at Komfo Anokye Teaching Hospital, Dr. Yao Opare Labi. Dr. Labi, welcome to the program. Komfo Anokye Teaching Hospital, one of the biggest referral hospitals in the country. Tell us, what is the situation like when it comes to emergency healthcare?
Thank you very much for the opportunity, and good evening to all panelists. I'd like to say good evening to our Honorable Sister, Dr. Grace Yensu, and Dr. Bonnie, who works with me on Komfo, and all listeners. I've been listening since 6 o'clock, and all panelists have really talked about the situation as it is. In Komfo, which is the second largest teaching hospital, but where we are situated, we receive referrals from, almost all over Ghana, about 12 out of the 16 regions, and beyond the border, like Côte d'Ivoire. We have 1,000 patients coming in every day. Now, when it comes to our emergency department, where Dr. Bonnie works, and actually, I'm proud to say that formal emergency, training and education and service started in Komfo Teaching Hospital, and we are helping to train other institutions in Ghana as well, and we have people coming from beyond to train. You see, the hospital is like a funnel at the beginning. So the patients come in, and then they move slowly through the thin part to the medical department. And as much as you may try to innovate, you may try to be creative to take care of patients. You have your limits, and we have to remember that it's our staff, it's us who are working, and you may get overwhelmed. The numbers can, when the numbers are increasing, then the chances of also making mistakes also increase. In Komfo, we have the main emergency department that in Kumasi popularly called the Kufuor emergency because of the time within which it was constructed. Then we have the pediatric emergency unit. We have the obstetric and gynecology unit as well. So we have various points. We have our family medicine directorate, which is like a primary care facility, but it belongs to us, and they also see emergency. So at all these points, patients come in. They come in their numbers. Now, what's happening is that if you have hospitals like Komfo with no other big facility complementing what we are doing, then it puts us under a lot of pressure. So what we have to do as the country is to make sure that there's strategic distribution of the various levels of health facilities around the country, so that people don't have to travel long distance. Now, when I talk about the health facilities, then it means that we must have tertiary facilities, or our regional hospitals must be well resourced. Human resource should have the necessary skills and knowledge. And I've heard us talking about attitude, so they must be professional, ethical in their approach. So at all levels of the health care, looking at the spectrum of the facilities we have to make sure that they all have the requisite training and the requisite facilities to take care of the patients who come there. We need to think about the 3 delay model. So quickly, the first level is patients or families deciding to seek care. So there may be a delay there. Then when they do decide to seek care, there could be a delay getting to the facility because of lack of adequate transport, because of the distance of the health facility from where they stay, because of bad roads, where we can talk about all these happen in our country. And we can talk about when the health facility, which is now under the spotlight. So what happens at the health facility? So in Konfanochi, we have bed management. So it's not digitized, but you see them moving back and forth on the phone, sometimes people making physical visits to the wards to see what bedding there so that they can move patients when there's space. You see, but it's tricky. Some patients will come in, arrive. Once they get to the ward, they may spend 3 days, 4 days, 5 days, 2 weeks sometimes. And not to talk about sometimes when they have to pay their bills, it may take some time for some of them to pay their bills. Social welfare may have to come in. That is why, as I said, it's like a funnel. They come in a lot and then they move through the system slowly. So what we have to do, about 3 years ago, myself and the current head of emergency medicine and someone from PPME in Konfanochi, we visited the last regional director of health services, and then we had a chat, and based on that, we drew up a proposal, which we called the Greater Kumasi Health System. And we also submitted it to the current regional director of health services. And it spells out all these things. In summary, we decided that we should have what we call the Greater Kumasi Health System, and we should be networked digitally. Someone should see all the categories of beds we have so that we'll know at any time, in real time, what is available. And if patients have to be moved from one facility to another, we know where they should go. Just like Dr. Bonnie talked about what he saw in UAE. So it's something that we've had so many conversations about, and we have to actualize it. We've had brilliant ideas, brilliant solutions. The important thing is making sure that we do it in a concerted way so that we don't do this knee-jerk firefighting approach. That won't help. We must plan. It's about setting up systems that work, systems that can undergo continuous quality improvement. It's a continuous thing, but we must be deliberate about planning properly and then making sure that we roll out things effectively. So, as I said, someone once asked me, if we finish your maternity block, the new one that's coming up in Konfanochi, which will probably take about 500 beds, if we complete it, will it solve your problem? And I said, that would be just a drop in the ocean. The reason is that you may even expand Konfanochi or Kolebu to 3,000 beds. It doesn't solve the problem. Why do people have to travel all the way? We've had patients coming in from OT region, and they move from one place to another until they got to OT. Yesterday, I had a call from Western North that one of the directors did. There was a mass casualty, and they wanted to send 4 patients to us, 2 head injuries, 2 mangled lower limbs. And this was just yesterday. And today, right after I left the maternal mortality conference, I got a call while I was driving, and someone was calling about another patient who is bleeding, a pregnant woman, and they want to send the patient to Konfanochi. And I said, bring the patient after discussing the case. You see, so people are coming from distance. And the care, and I remember saying that, give this medication so that we know that the patient is getting the care and it's continuous. So it's seamless care from the hospital during transport, and we continue when we receive the patient. And then I went further to alert our team in Konfanochi to expect the patient. So you see, communication is important. So we need to use everything. We are talking about health, the health of the human being. If you look at the way our bodies work, our bodies are very efficient because signals are sent to the right place at the right time when everything is fine. So our bodies are made up of various systems which are working beautifully together. And that is how we should also, that's the kind of way we must develop our health system for it to be able to work very well and also be able to develop it continuously, bringing in new innovations at the right time. The human resource, that's the best resource that we have to be very well motivated. You see, there's one thing, I don't know if it's come up in the conversation. People find it difficult to sometimes work in certain areas because some of them are family people and they'll be couples. Some people will be thinking, where are my children going to go to school when I move here? I want this level of education. I don't want my children to go to a place where the school building is crumbling and can collapse. So we have to sit under trees, or we are sharing the classroom with goats and sheep and fowls. You see, so people think about all these things. And that's why you may find people, when postings come out, people are clamoring to be posted to certain places because they want to have some level of comfort, not just for themselves, not because they are selfish, but because they need to ensure that their families or their dependents, especially if they are young children, are getting the exposure, they are getting the right education that they need. So when you post a doctor or a nurse or a laboratory scientist somewhere, you are putting the entire family over there. I've seen people who had to allow their wives to stay in Accra for the children to get an education, but they were working all the way in the district, and they have to travel so many times, and some of them had accidents because they had to be commuting up and down to visit family over the weekend. So the development itself, you see, the health sector development goes beyond just developing hospitals, but you have to make sure that all the regions and the district have certain facilities which make people comfortable to move in there and work. It's not enough to say, I'm going to give you a house, I'm going to give you a brand new car, I'm going to add this to your salary. You may do all that, but they may not go. So that's why we have to have a very holistic approach to national development. Even though we are talking about health, we know that everything else in the country impinges on this, and we have to make sure that we develop everything so that the health sector we are talking about will also develop in a holistic manner.
Dr. Labi, what is one urgent action you want Ghana to take now to ensure that our emergency health crisis at least reduces? One urgent action.
So if you look at the three delays I talked about, so I'll say we should look at two immediately. So, and first, we have health facilities around the country. I must say we must take pride in what we have and develop it. So with these health facilities around the country, we should map and see where are they located. How can we bring them up to the level? So what we should do is to do an upgrade by way of human resource and facility for the existing health facilities, those that are complete, those that are in various stages of construction. Let's complete them and make sure that we equip them and resource them with human and various logistics. And then after that, let's make sure that transportation of patients is such that it becomes very comfortable. How are our roads? How are our ambulances? We have to make sure that we have the right transportation system. Then it's very important that we network. You see, now we have technology. We network the entire country. Various districts, various regions should be networked so that we can, in real time, see what is available and know how to move patients to the appropriate place and minimize the issue of going here and being told that we don't have space, going here and being told that we don't have space, or even sometimes they say, call and ensure you have a bed before we move.
Right.
That shouldn't happen. When an ambulance has to move, it has to move. Now, one important thing is the attitude of we, the health workers. We've heard about our doctors saving lives on some of the long-haul flights across the Atlantic. They are our own doctors, some of whom Dr. Bonnie and I know, and they were commended for what they did. They were on a flight. They were not ready. They didn't know there were going to be sick people. Someone gets a cardiac arrest. and they resuscitate them, and the people survive, and they get to their destination, and an ambulance is waiting there. See, so what is important is that we should have that good Samaritan. We should have that good Samaritan spirit.
Oh dear! Unfortunately, we've lost Dr. Opare Labi, who's the Deputy Medical Director at the Komfo Anokye Teaching Hospital. I understand we still have him on the line. Can you hear me?
Yeah, you sir.
Right.
Can you hear me?
Your sound is much better now. I can.
Thank you very much. So what I wanted to say lastly was that when we were in medical school, we were taught to be good Samaritans. I remember my ENT lecturer telling us that when you get to an accident scene sometimes, and you may find out someone is having difficulty breathing, it's very loud, and you put your hand just below your Adam's apple, you feel your trachea. Maybe his mouth is full of blood and there's a fracture, and you may feel your trachea.
Right.
You can even make an incision right there, and they may begin to start taking air into their lungs, and you've bypassed the obstruction. So the issue of patients arriving at a facility for someone to tell them that we cannot take you should not even come in, because I am an obstetrician. We've delivered patients in the taxis at the hospital gate. They tell us when we run there with gloves and things to cut the cord, and then we bring the baby in and the mother into the hospital. So this issue is something that everyone must do. And as a health person, and even the ordinary person, is supposed to know to do basic life support. If someone collapses in the supermarket in front of you, you should be able to call for help. How much more a health worker who is in the hospital and someone arrives, right, and you say that the person cannot be seen? It's unacceptable. We can't blame it on congestion there. We can start treatment in the taxi. That's where, because we've treated people on the war front, on the field, where there's fighting and bullets are flying around. People have treated patients like that. We see it all the time on TV and in movies. See, so that aspect there. So briefly, what I'm trying to say is that 3 things. Let's develop the health facilities we have, upgrade them, make sure there's equitable distribution in terms of distance, accessibility. Let's make sure that they have the facilities, and let's ensure that the staff are well motivated, that there's ethical leadership, there is accountable leadership, there's integrity in the work. Thank you very much.
Thank you, too, for your time this evening. Dr. Yao Opare Labi is the Deputy Medical Director at the Komfo Anokye Teaching Hospital in the Ashanti region. Let's bring in Dr. Darius Osei, who is a former CEO of the University of Ghana Medical Center, also known as UGMC. Dr. Osei, welcome to the program. Briefly, the UGMC that you used to work at, and you used to be the CEO, did you ever confront any medical emergency crisis of this magnitude that we've been seeing of late?
Thank you very much. I'm happy to be here. And my greetings to all the panel members. I've listened attentively to what has been discussed, and I share everything that they've said. Having spent all my life in the hospital, probably I will limit myself to the public health aspect and then concentrate more on the hospital. I also want to express my sincere condolence to the doctor in Cape Coast. I happen to be a medical director in Cape Coast from 2002 to 2006. That's in the tasting stage where Interberton Hospital was started. And I'm happy to hear that they've kept that culture, that patients are not sent away. Because I remember very well that I introduced total nursing care. I had a lot of challenge, but it succeeded. And I must say again that I worked in a district hospital for 10 years before I came to Cape Coast. And then I came back to a private sector, like the Senate Hospital, for 12 years and ended my career in UGMC. I've listened to most of the discussion here. And I must say that in every referral hospital, the key performance indicator is the number of cases that are referred to you, and then the morbidity and mortality that comes out of it. So my message probably is limited to managers of the big hospitals, that the focus must always be at the emergency department. Because if you are to come on show in the public, then mostly it is what happens in the emergency that keeps the light on you. When I went to UGMC, I think I had the opportunity to bring on board what I had experienced through the district, the region, and then probably the public. I realized, and I lost a patient, that is my niece, who was in the university. I stood by her in the emergency. We spent 4 hours. I was sent to go to the lab to bring the bottle, and I brought it, and then, up and down, up and down. And so finally I lost my niece. And when I got to UGMC, I realized that the emergency unit didn't have a lab. It didn't have a pharmacy. They were all away from the emergency unit. So because UGMC was new, I managed to fix a pharmacy in there.
Right.
And then fix a laboratory in there. And then we have the photo imaging, all of it around it. And there was a policy that no money should be collected from any patient within 24 hours. And patients must be attended to within 10 minutes because it's so cumbersome going around with documentation, getting payments done, and so forth. So I think it worked. And I'm happy that UGMC so far has not come on the show, because anybody who enters the emergency unit, no money is collected. You are seen within some few minutes. And the emergency had the pharmacy to provide you all the medications you need and all the photo imaging you need, as well as all the laboratory services. And that is the reason why it is called emergency.
Right.
So probably we must look at all the places because it has its own context and definitions. We don't have standards.
Right.
And standards are important. And I believe that let's standardize our operations. Let's make sure that emergencies are defined in a manner that merits what is a man. Nobody carries 20,000, 10,000 in his pocket. And sometimes even it is the Good Samaritan who carries patients to the hospital, and they have to go pay this, pay that, pay that. Right. And by the time they finish paying, patient is dead. And so let's redefine ourselves and see.
Right.
All the other things that the panelists have spoken about, I share it, and they have spoken very well. But let us also look at, I work in the district hospital for 10 years. I never saw a sound machine. But these days and time, it has become part of our diagnostic tools because students are being trained with these tools, and that is all they know. Let us let us get this running.
Right.
Let us get them properly, well resourced, because the Ghana West Africa program and the Ghana College is doing well. They are churning out a lot of specialists. They are all concentrated in Accra because they don't have the tools out there. But I believe that if for nothing at all, each district hospital should have a CT scan, ultrasound.
Right.
And then we can decongest most of these facilities in the in the regions.
Dr. Darius Osei, thank you very much for your time. He's the former CEO of the University of Ghana Medical Center. Let me come back to the studio. We're wrapping up, ladies and gentlemen. But I want to pick your final words, briefly, 30 seconds each. Minister, I would want to start with you. What is that one urgent action that, when you move from here and you go to cabinet, you propose to government to ensure that the medical emergency crisis that we are witnessing will at least reduce? 30 seconds.
Thank you. I think that so far we have proposed all the proposals and we have all the answers. I think that what we have to do is the implementation and implement it right. There's not much to say. There's no more data. We know the issues. We have discussed it ad nauseum. Every one of our guests have said just about the same thing. A lot of the things we said were cross-cutting. And the government currently, on behalf of the government, we have put a lot of systems in place to address a lot of these issues.
Right.
The stakeholders engagement will happen, and we'll put in place a hospital management system that is integrated with the pre-hospital, which is the ambulance management systems. And then we will do the training and do the best, really, under the circumstances to absorb the nurses and the health professionals that are home. We may not be able to do everything.
Okay.
We'll do our possible best to address some of these issues. These issues are long-standing, but I think that we are in the right place and the right time and the right group of people, and the president is really committed to health care. So I think that things will look better. They've already started looking better and will continue to do better. Thank you.
Minister, thank you. Dr. Saponosiedu, your final points, 30 seconds.
Well, we've been talking for far too long. At the moment, a few things are happening. They need to happen at pace. We cannot afford another national dialogue on this. That would be too far-fetched. And we would come across as an unserious group of people. And I'll end this way. If we sit for this crisis to take people while we keep quiet, one day it will take all of us.
Madam Perpetua.
Thank you. So our emergency healthcare crisis it just reflects inadequate healthcare access and a system dysfunction, which is more about poor coordination, overcrowding, poor staffing, and resource gaps. And I think a lot has been shared here. I think we've talked enough since as far back as 2012 till now. And it's about time we fix it. We must fix it. But in the meantime, we must increase our capacity to ensure that there's more preventive and promotive health in Ghana. We must ensure that we address the social determinants of health.
Right.
And we must ensure that we carry everybody along in terms of stakeholder engagement and ensure that nobody loses his or her life unduly in any emergency unit in Ghana. Thank you.
Dr. Ba?
So it's clear, we know what the solutions are, and everybody is saying action now. We must all come on board, all stakeholders, including the patients. So together we can bring on the solutions. And as regulators, we'll also do our part. And I'm happy my minister and the deputy, they are doing very well. This time it's no more talk, action. And I'm sure we'll find solutions.
Dr. Bonnie?
I think some of the action also has to pertain to the patients. Good health-seeking behavior to reduce the number of patients that are coming to the hospital, but that education extending to the healthcare professionals, train them to be able to receive emergencies, even at the medical school and the nursing school levels, which is now missing, to be able to make sure that we have people that are ready out of school to be able to see basic emergencies, and promote the integration of not just stakeholders within the government space, but the Ghana Medical Association, the Emergency Medicine Society of Ghana, and all other stakeholders who contributes in any way within the emergency care ecosystem.
Thank you very much. Many thanks to our guest. Dr. Grace Ayensu is the Deputy Minister for Health. Dr. Winfred Barr is the Registrar of Health Facilities Regulatory Agency, otherwise known as HEFRA. Dr. Joseph Boni is an emergency medicine specialist. Perpetua Ofori Ampofo is the President of the Ghana Registered Nurses and Midwives Association. Dr. Kwame Esiedisapon is a CDD Fellow. We also had the Deputy Director of Komfo Anoche Teaching Hospital, Dr. Yao Opare Labi. Dr. Darius Osei is a former CEO of the University of Ghana Medical Center, also known as UGMC. We also heard from Dr. Levi Ankra, who is the Vice President of the Kolebu Doctors Association. And tonight's discussion has made one thing clear. This is not just about beds. It's about whether Ghana's emergency care system is organized, responsive, and equipped to save lives when people need help the most. We have heard the data, the official response, the regional experience, expert perspectives, and the heartbreaking human stories behind the crisis. And the challenge now is turning concern into action. Thank you to our studio guests and the ones that joined us on Zoom as well. And thank you to our viewers for the messages and participation. My name is Kenneth Jesse. This has been the Joy News National Dialogue on Ghana's emergency crisis. Have a good night. Right after here is PM Express Business Edition with George Wiafe.